All right, let's wrap up by talking about our invasive carcinomas of the breast. Remember, these are going to be cancers that break through the basement membrane and are really aggressive and malignant. So these are the ones that we really do not want to diagnose our patients with. Let's start by talking about invasive ductal carcinoma. This is going to be in the ductal region. And so this is going to be the progression of our ductal carcinoma in situ. This is going to be the most common type of invasive breast cancer. And this is often going to be bilateral and multifocal. So this is really nasty disease process. It's going to present as a hard mass with well-defined margins. This is going to be firm and fibrous tissue, and it's going to have desmoplastic stroma. Desmoplastic stroma is referring to the fact that fibrous tissue is trying to grow around this cancer and contain it, and so that is the response of the body to this really invasive cancer. And then these cancer cells are going to be described as small, glandular, and duct-like cells because this is going to be a cancer that is arising from the ductal tissue. Let's move on now to talk about our invasive lobular carcinoma. This is also going to be frequently bilateral, so this is going to be nasty disease as well. And like we talked about with our lobular carcinoma in situ, this is going to be all about cadherin expression. So here we have decreased E-cadherin expression, and this is going to lead to tissues that do not stick together well. So this is going to present itself as metastatic disease that is spreading away from its original location. And important here is going to be single file cells, which we are going to zoom in and look at here. And essentially these cells are going to line up in single file because they are now migrating. They have lost their cadherin expression. They are no longer sticking together. And so they're kind of marching out of their original location past the basement membrane and going on to metastasize. This is going to have a lack of duct formation because the ducts are essentially getting so deranged that these cells are spreading everywhere. And this is frequently without desmoplastic response. And remember, desmoplastic response is the body trying to create fibrous tissue to contain this cancer. And this is not happening because this is a really aggressive malignant disease process. So if we look here, let's do some compare and contrast. Our lobular carcinoma in situ is all contained nicely here within the basement membrane. However, with our invasive lobular carcinoma, we're going to start to get single file cells like these here, some more single file cells here. So these have lost their cadherin expression and they are just going on a march. They are marching to malignancy. That's how I like to remember this. And this is going to be a really, really poor prognostic sign. And this is the characteristic lack of desmoplastic response in this invasive disease process. Let's move on now to talking about medullary carcinoma. And this is going to be characterized by specific molecular things that you have to know with regard to this cancer. It's unlikely that you're going to get histological images, but you're going to have to know that these are large anaplastic cells in sheets and that they're going to be lymphocytes and plasma cells. So I want to highlight this in purple because I think of lymphocytes and plasma cells as really purple cells with like big nuclei. And so that's a way to really recognize this on test day. And it's going to be a well circumscribed lesion and it's going to be a mimic of fibroadenoma. However, the fact that this has the lymphocytes and the plasma cells is going to clue you into the fact that this is an aggressive disease type. Lastly, let's talk about our inflammatory carcinoma, which I'm going to highlight in orange, and you guys will see why in a second. This is a really, really terrible disease with a poor prognosis. Only 50% of patients survive past 5 years, and this is going to be a mimic of eczema and Paget's disease, so it's important to rule this out when you're working up patients. It's going to present as a painful, warm, swollen erythematous lesion or breast, and there's often no palpable mass here. So how are you going to recognize this? And the key physical exam finding is something called peau d'orange, and peau d'orange roughly translates to orange skin, and this is caused from hair follicles that are undergoing changes because of this cancer. And so this peau d'orange finding is what you see in the picture here in the chart, and it looks like the skin of an orange. And so if you were to see a picture of this on exam day, this is a big high yield red flag for our inflammatory carcinoma, and this is caused by invasion of dermal lymphatics. So we know that our dermis is going to be drained by lymphatics here, and so when those lymphatics are invaded by this cancer, it's causing like this little orange dimpling effect at the surface of the skin, and this is how you're going to nail this one on test day. So remember guys, everything on this slide is going to be invasive malignant disease, and this is important to separate from our previous slides, which were non-invasive carcinomas or benign lesions altogether. I hope you guys enjoyed this video on breast cancer. Can't wait to see you guys in the next one. Bye!